2016, we had a patient come who referred themselves to go flat. And then on our microbiology analysis, looking for bacteria, fungus, mycobacterium, it showed that she had E. coli infection. Had nothing abnormal. Her history, I just went back through everything that she subjectively told us. And it had this indolent infection for an unknown period of time. Didn't know anything would come of this. This happened, and this is going on. I'm not going to discriminate and say this, I just found this in a cancer patient. How many cosmetic patients could have the same problem?
Yeah, exactly. Thank you so much, Rob, for being here. Dr. Rob Whitfield, because you are, I know it's funny. I had a client, I'm not kidding this, Rob. I had a client and all of his credit cards said doctor on them.
Okay.
And then, and I jokingly was not even thinking about the doctor. I just looked at the last. I'm like, oh, thank you, mister. And he goes, I didn't go to all those years of school to be called mister. And I thought it was the funniest thing. I thought it was a joke. He was serious. So now it made me aware that some doctors may want to be just called doctor. And so that's why when I greeted him, I needed to know, is it you like to be called doctor? And you're like, Rob. And I'm like, all right, cool. We'll call you Rob.
So I worked at Cambridge, and the surgeons there are referred to as Mr.
Yeah.
And the other doctors are called doctors. Everybody else except for surgeons.
So the professors are the misters?
No, surgeons.
Surgeons. Oh, surgeons only.
Yep.
Okay.
That would be Mr. Whitfield.
They wouldn't call you doctor. No. That's interesting.
Yeah, it's the surgical consultants because they're from Bloody Barbers. They started as barbers.
Yes, which is where the pole comes from.
Yep.
Yeah. So what you're saying is that go back 200 years, I may have been a surgeon.
That's right.
Okay, funny enough. Now, I don't know if I have the skill set or not, but I used to get suits custom made by this custom tailor out in California when I lived there. And I would say, hey, man, this isn't really matching or whatever. And he was pissed at me because there was a series of suits that came in. Right. They just weren't right. And he goes, you and my surgeons, my most difficult clients. And he was pissed. And I said this, I go, and it was like that, it was like the scene in Dumb and Dumber where it's like, where he goes, there's a 1 in a million chance. And he's like, so you're saying there's a chance? I'm like, I was like, so you're saying I have the eyes of a surgeon? He's like, no, that's all I heard. And I heard it that I have the eyes of a surgeon. I don't know if I have the technique, but I definitely do have a steady hand and have an eye for nuance.
Right.
If I could just get over the blood and guts saying and the operate on cadavers, I think I would be okay.
There you have it.
Yeah, that's the hard part. Same thing with dental school. You have to do that too, a dental school to become a dentist. And I was like, what? So, all right. Rob. Your hair's long. You're going to keep it long.
Yes.
I'm down for that. High and tight. No, I'm kidding. So, about how much length do you want to take off?
I think we saved this for you. So it's either 1 or 2 inches, but it's probably long enough now for 2, I would imagine.
Where do you like, when you wear your hair down? Because I know in a lot of your videos, stuff, you have your hair up. And yeah. So when your hair's down, when it's like this, like casual Saturday or casual Friday, where do you like the hair to hit? Do you like it to break past the shoulder? Because it's pretty long, dude.
Yeah, probably just
like around in this area.
Probably a little bit higher.
Do you need to put the eyeballs on so we're clear?
Probably a little bit high. I mean, more towards my collarbone.
More towards the collarbone.
Yeah.
Okay.
I've gotten it. I've grown it out for you. It took time to schedule this.
Yeah. The schedule was actually so quick.
Yeah, everybody should understand that I'm kind of lazy about getting my haircut.
There's nothing wrong. All right.
Just getting more gray, which is hilarious. Or white or whatever.
Were you blonde growing up?
Yeah.
So you're just going back to blonde. You're just going to be the ultimate towhead. That's what I told somebody. I go, I hope that I just go gray.
Yeah.
And then I'll go white. And then I'll go back to being a little Targaryen. And then I'll be fine.
Yeah, it was blonde and then now it's just white.
My wife tells me all the time that I'm not blonde, and then I'll go to the East Coast and everyone goes, you blondie. And I'm like, I'm blonde now. Yeah. I'll be
New York, New Jersey.
Yeah. And they're like, look at you blonde. You blonde, California.
Well, I'm a albino there.
Yeah. Yeah. And then you go to California and, I worked in Newport. So I always called it Newport bleach because, yeah.
Fair.
Doesn't matter how much the colorist would go through and lighten the hair. They'd always be like, I still see yellow. And I was like laughing, like, so glad I'm not a colorist and I don't have to deal with this shit. All right. So you are a plastic surgeon, right?
Yeah.
And you have it feels like you have a specialty. Am I wrong on that understanding?
Yeah. So most plastic surgeons who just do aesthetic surgery concentrate on either a region, or some may try to do the whole body. And the reasons I did not gravitate that way from the end of training was because I was very interested in cancer reconstruction. So I'm a plastic surgeon who trained for 6 years in general surgery, so I could take out your colon, do your liver surgery, do your hernia, gallbladder, all the things.
Yeah.
And then I spent a year in a vascular biology lab.
Okay.
And I got really interested in microsurgery during that year.
Oh, okay.
So you use a microscope to perform surgery. And to your point of the eye for the flaw in the suit, I got really interested in doing microsurgery, which is usually using, a suture, which you would consider like a thread.
Yeah.
And it's finer than my hair. And that's what you use to connect blood vessels. So think of like the tiny, tiny coffee stirrers. You would connect those using a microscope.
That's crazy.
So that's what I liked to do. That limited then my options afterwards. You couldn't really do a lot of different things. If you wanted to do microsurgery, there was really plastic surgery, or otolaryngology or ENT plastic surgery. And I wanted to do things all over the body. So plastic surgery just gives you the opportunity to work on the head and neck, or the torso, or the chest, or the back, or the leg, or whatever. So that's the most diverse specialty by far.
Mm-hmm.
So then I did plastic surgery for 2 years. And then because I wanted to do microsurgery as the profession within that discipline, I did another year of microsurgery training after that. So I did 9 years after medical school. So 13 years after college.
That's a lot of schooling.
Yeah.
That's a lot of learning.
Yeah. Well, you don't want an inexperienced surgeon.
No, absolutely not. You want somebody who's gone through all the training. Okay, so here's what I'm gonna do. I'm gonna put a cape on you.
Sure.
And when I put the cape on,
We
gotta remove that. Yeah. So let's do that, and then we'll get started.
Yep.
We are set. We're gonna do some hair cutting, and I want to hear a lot about this. So, as a hairdresser, the majority of my clients are women. And over the past few years, the topic of plastic surgery has always been a discussion.
That's never gonna stop.
Yeah. Oh, I remember this. I was 24. This is actually a really funny story, and it's a really good time to talk about it, because talking about this with another guest would be like, that came out of nowhere. But this is relevant. Before iPads, before iPhones, you would have to bring pages of photos of what you wanted your hair out, or a book.
Yeah.
This one client, she was like, oh, by the way, and she had her consultation with the colors, and the colors went to go mix up the color. And then it was my turn to talk to her about what we were going to be doing with her hair. Now, I've cut her hair many times, so the consultation isn't the same as like a new client. We're trying to find like certain lifestyle choices so that we can find the best style and whatever for a client. And she goes, by the way, I have a photo. I want to ask your opinion on something, if I should do this or not. And I'm thinking, it's like
a boob photo.
It was Playboy.
Yeah.
And it was this girl. Two or three photos. And this is like a Friday at like 4:30. And I am thinking, and my first response was, well, why don't you ask your husband? Like, you're married, like ask him, right? She goes, well, he doesn't want me to get these. And I was like, okay. She goes, so she goes, which one do you think would look better on me? She's like holding up the photos. It was so awkward, because she's just basically showing pornography, in the whole salon. She doesn't care.
Yeah.
It was, and I was like, she goes, I need an answer. And like, I felt really pressure. I didn't want to give an answer, but I was like, those, a few months later.
So that was the validation for her to.
Yeah. I go, well, if you're going to go, I like those, and it could have just been the person, But what was funny, a few months later, she specifically wore a very tight, low-cutting shirt. She goes, I got them. And I'm like, well, there's no way of not knowing. It's like, it would be like me now and then me later getting double Ds. It was like an impossible thing not to notice.
Right. And that's part of the problem.
But I will say, I've definitely, I've learned a lot because I've had clients that were plastic surgeons. I've had, but never dealing with what you do, which the topic lately has been coming up, is this idea that the breast implants could be causing some sort of autoimmune or some sort of inflammatory response. And the way it was explained to me is that there's these things with the implants that are creating some sort of response into the body, and the body doesn't know how to deal with it. And so it responds in a way where it just does it. The only thing I could think of is like if you got some sort of organ donation or you got a transplant of something, and you have to make sure, does the body reject it? Yeah. And this is a foreign object. It's not made of natural material. It's made out of plastic, silicone, all sorts of stuff. It doesn't seem like a very hard leap of logic to think that something that's not produced by the body would reject it. Now, I would love you to be able to educate me on this. Yeah. And like how crazy am I off on my understanding? Has it been explained to me incorrectly? You're the expert on this.
So all of the things that we have done, I think on my channel, I have 4,000 videos and 180 shows. And we talk about, if you want to think of the reaction, traditionally you're taught that there's a foreign body reaction when you get a splinter.
Yes.
Or a piece of glass stuck in your foot, your hand, or whatever. And until you get it out, your body's trying to wall it off. So it's always been taught that is the same reaction that's taking place around any device. Now, there's a lot of different devices used for a lot of different reasons. There's pacemakers, there's defibrillators that help, prevent you from dying from an arrhythmia or too rapid of a heart rate. And there's hip implants, knee implants that we use when, patients have, in the orthopedic world, have, their joints unable to be either rehabbed or, with a biologic improved enough so the patient's not experiencing so much pain with just walking or movement up and down. So they'll get a joint replacement. And that's done typically with titanium, sometimes porcelain. And then you have dental implants. That's a whole another.
I got one.
Yeah.
I felt like I had a kinship with the clients who had implants as well. I'm like, I have one, you have two.
So that's a big issue as well.
Okay. Yeah.
That's why biologic dentistry has become such a big phenomenon, really. And Kelly Blodgett, Dr. Blodgett's in Oregon, and then Dr. Nischwitz is in Germany. And those are the two biggest people, I would say, in the world. So there's all these different implants, right? And they all have different, and serve different purposes. So the first breast implant was placed in 1962 in Houston by Drs. Cronin and Giroux. It was a silicone elastomer shell filled with silicone. It's a Dow Corning implant.
They made an HBO series about that with David Schwimmer playing doctor. I remember seeing, like, I didn't know that they had.
It's a movie, actually.
Oh, movie. I
it's remember breastmen.
Yes. And I just remember going, they came out in the 60s. I did not, that was a new thing for me. I thought it was something that maybe it would just happen in the 80s. So
we'll go back to one of the things you said was kind of if you're an autoimmune disease. So just so that everybody's super clear on history, autoimmune disease is started in the late 1800s.
Okay.
And the first breast implant was placed in 1962. So that's not that it doesn't or can't contribute, but those all predate implants.
Yes.
And then kind of one thing that you said, can your body deal with something like an organ rejection? So the first organ transplant was done in the 50s by Dr. Joseph Murray, who's a plastic surgeon, actually. to a kidney transplant at Brigham Women's Hospital to a genetically identical twin.
Okay.
So a Siamese twin that obviously is a genetically identical twin can receive an organ transplant from another Siamese twin.
Yeah.
So twin. And if they're identical, then the genetic code is the same. There needs to be no medication. It can't get rejected. So kidney transplant, probably partial livers, if you could execute it, lung transplant, single lung, whatever. All those would just be interchangeable parts.
Okay.
Because the genetic code is exactly the same. Everything after that needs some sort of immunosuppression because your T cells mature in your thymus and they recognize everything that's yours as self.
Okay.
And everything else that's not as foreign. So no matter what you put into somebody else, if they're identical twins, but they're not genetically identical, so non-identical twins, they would need medication in the form of like a steroid or another immunosuppressive medication to block that person's response to that order.
Okay.
And then a cadaver, so between you and I, we're not related, that would require the most immunosuppressive medications to block the response because you would get rejected.
I had a friend who got a cadaver knee replacement.
Similar, but that's not a blood flow restoration. So it's something that brings blood in and out.
Okay.
Like a vascularized transplant, which is what I used to do for cancer reconstruction.
Yeah.
And so I'll try to tidy it all up. So genetically identical twins don't need immunosuppression. Non-identical twins do. Cadavers need the most.
Got it.
Cadaver transplants. And that's how transplantation actually works for organs.
Okay.
So we're going back to the breast implant.
Yeah.
So we're all taught that it creates a foreign body reaction, but if done properly, just like all the other implants, it should allow the patient to, whatever we're doing, have the reconstruction of that area. Now it's foreign, it's not the same. So my discipline of microsurgery was different. So I would take tissue from other areas of the body connected to blood vessels, kind of like the organ transplant.
Got it.
And make a breast reconstruction. So I could take tissue from the lower abdomen using the blood vessels that run in the six-pack muscle.
Okay.
They pop up like sprinkler heads and feed the tissue of the tummy.
Okay.
So the tummy tissue that's thrown away in a tummy tuck can be used to make breast.
Okay.
So that's what I used to do.
Okay.
And I used to do that for breast reconstruction. And then I could make a tongue. I could make your esophagus. Yeah. I could make the jawbone. And those were all done with your parts. So once again, going back to the genetically identical hypothesis, those can't be rejected.
Okay.
If in fact you hook up, think of like a cord you plug in the wall. There's two prongs, artery and vein, blood flow in, blood flow out.
Yes.
If you did those properly, then all things being equal, that would help that area by reconstructing it. If it was a cancer surgery where it had been radiated or it had been damaged in maybe the patient was in a car accident or motorcycle accident or fell or whatever the incident or an infection that got out of hand, then you had to remove parts of somebody's, muscle or skin, fat, muscle layer, whatever it is.
Yeah.
So that's what I did. I did not use a lot of implants for breast reconstruction because I was doing that very time-consuming work I just talked about. Those are not short operations; they're very long operations.
I imagine, I feel like with some surgeries, the way I've had people talk about it, the longer it takes to explain the procedure, the longer the procedure it actually is.
Yeah, they can be. I mean, those take several hours and a lot of equipment and staff and specialized instrumentation and care after. And there's just a lot of components that go into multidisciplinary cancer care. And that's what I did for the majority of my career. So I get asked, why are implants used so often in reconstruction?
Yeah.
Okay, so we just had the World Cup for everybody. And so Spain won the World Cup.
Yeah.
So we're sitting in Texas and close to Austin, the capital. The entire country of Spain fits inside of Texas for everybody listening. And so it makes it a little challenging to be in our country, which has over 350 million people in it, and is quite vast. So if you get out of an urban area into a smaller area with a community-sized hospital, and the patient has breast cancer and needs a mastectomy, which is a breast removal and a total breast reconstruction, the most common method available in that community-based hospital will be an implant-based reconstruction, because the plastic surgeon available has to be able to perform that to be board certified or board eligible in plastic surgery. They do not have to be that. They do not have to be able to perform everything I learned how to do in 9 years of training. Because that requires, once again, a hospital that's invested quite a bit in terms of an operating room microscope, instrumentation, specialized nursing care, specialized surgical techs, monitoring, all these different components. So an implant doesn't need specialized monitoring afterwards, doesn't need an operating room microscope. So the point is, it can be done and delivered, and the patient should know all the options and then decide. And that's probably the biggest deficit. But that's why implants are always going to be the most common form of breast reconstruction, not just in the United States, but in the entire world.
Okay.
So they're never going to stop being used or stop being placed. And I get asked it all the time, what's the safest implant? Okay, so I'm not a regulatory agency, right? Yeah. Regulatory agencies determine safety and efficacy, not Dr. Whitfield. So they deem that. Yeah. There are tools to be used in the circumstances needed after the patient has given informed consent and made their own decision. So I think most patients would be better served if they just had a better explanation about what's potentially a problem.
Which is communication.
Yeah. So that's really the feedback I get from most patients. Either I didn't understand completely, and that happens sometimes when you get things when you're too young. Mm-hmm. And my daughter's 18 today, for everybody listening. Wish her happy birthday. And so I get often asked, would I let my 18-year-old daughter get breast implants? Well, for everybody listening, I'm a Leo, and so is my daughter. And if you know anything about Leos, you can't really tell them anything.
That's my rising sign.
So you don't tell a Leo anything. You give them the information, and they choose to do what they're going to do.
Yeah.
So I couldn't stop her if I wanted to. She would cobble together the money saved in some sort of vessel, piggy bank, whatever, and go do it if she wanted to. Yeah. And that's the only thing you want to do, which you would hope to, at the end of the show or my career, know is that if you gather enough information to let somebody make a decision, then that's their decision. That's basically it.
I think that's one of the things that I've always prided myself as a hairdresser, saying, like, when somebody wants to do a big change or whatever, I'm like, here's all the outcomes. Here's all the things that you'd have to do with your maintenance. Here's your this and here's that. And then let them make the choice. Yeah. Because what I may want to choose for them may not fit the lifestyle. And so you have to let them, and I also have to like make sure they understand, like, all 3 or 4 of these options are going to be fine, but one of them you're going to love more. And I need to know which one that is. And I will perform that one for you, but I want you to know all the options that you have available, because sometimes somebody will say, I didn't know I could do this with my hair. I'm like, you absolutely can do this with your hair. And hair is not nearly as life altering as surgery.
Right. But it can be. No, I'm just kidding.
I mean, look, if you had a
bad haircut's a bad haircut,
especially if you're in the public eye, a bad haircut, it can be definitely bad. Sure. But I mean, I think that that's something that good doctors and surgeons, whatever you want to, medical field, are the ones who give all the information and let the patient make the choice, which is
right.
And I've also had clients tell me that they felt that they were bullied into a procedure by their doctor too, because that the doctor didn't want to explore the other potential options.
Yeah, I mean, that's you got to understand, like, surgeons are, always like, I'm always right, basically.
Yeah.
I'm a Leo and I'm a surgeon.
Yeah.
There's probably not a more type A person that wanders around than someone like me. So, but it's my like duty to make sure I understand all the things that from a risk benefit ratio, outcome ratio. I can explain the best of my ability so that people understand. Mm-hmm. That's yes, always, and I've got 30 years of experience. So it's rare that I have some outcomes that it can't be kind of forecasted, but as you take care of patients who are all bio individuals, you will definitely come into outcomes from time to time that don't make a lot of sense.
Yeah, they weren't on your bingo card, as they say.
Yeah, because everybody is not, how do you want to say?
They're not carbon copies. There's no Xerox of people.
Well, I say a couple things, and this won't make sense to most, but so if you are critically ill and in, say, a really monitored setting, say you're in a house fire and you got a lung injury and you got severely burned, you would go to a burn unit. Mm-hmm. And they would have to, in order to keep you alive, give you enough oxygen, because you can only live 4 minutes without oxygen. They would have to give you enough nutrition through your GI tract to keep you alive. Otherwise, you'd get more and more problems with infections, and you would not get enough nutrition to heal.
Okay.
And then because the skin was dead in many areas of your body, they would have to be released so it wouldn't restrict blood flow. And then after about 3 days of giving you IV fluids and making sure you're oxygenated, they'd have to start a process of operating on you, basically, and removing dead skin and replacing it with your own skin. Because remember, we said genetically identical will work, or in the interim, you would use cadaver skin because that would be the step before. But ultimately, you could salvage and save and help these people, to survive.
Yeah.
Only if you basically took away all their privileges and gave them back one by one, right? So eventually you'd get them healed by getting their skin coverage back. You would allow them to breathe on their own, eat and drink on their own.
Yeah.
All of that has to be given back. But when you have somebody who is just coming in and out all the time, and before we started this, we talked a little bit. My program starts from when I talk to somebody, and it's got a curated set of supplements and testing that go along with it from a functional standpoint and genetic standpoint to highlight detox pathways, toxicity burden, gut health, food sensitivities, hormonal balance. Not basic blood work, because everybody's typically had copious amounts of that. I don't need to do that. And then due to the influencer industry, everybody's got or hawking some sort of supplement. But we just use supplements that are liquid liposomals to help support specific detox pathways that affect our patients based on genetics that we've evaluated in our audit of our patients. So about 83% of my patients have problems in genetic pathways like the vitamin D metabolism, like antioxidant pathways.
Like my wife can't. She does not produce vitamin D relatively as easy. Like I remember when we were pregnant, which won't we, she like the amount of vitamin D she would have to consume to get her her thing stable. And then when we looked up genetic things that we got from our 23andMe thing, she has a genetic disposition where her body doesn't really produce vitamin D as easily as somebody else.
Yeah, it's a mutation in VDR-GPX. There's two genes that control most of it, conversion and then transport.
Yeah, and then she has a version of MTHFR.
Yeah, so that's like 36% of the population has an MTHFR mutation. I do.
Yeah, I do too.
Yeah. So methylation is an important aspect, which is what MTHFR is part of. It's just one of, many genes involved with methylation, but some people have made a shit ton of money talking about 4 or 5. And then glucuronidation and glutathione's a peptide that everybody's been trying to use for beauty which is kind of weird. But ultimately, it's really important in dealing with biotoxins, things like mold toxins, environmental toxins, PFAS, pharmaceuticals. So there's lots of things that affect us. And I always say you can't pick your parents and you can't outrun a bad diet. So if you have bad genes from a detox standpoint, that's a challenge. It's not like an indictment. It's just you need to know it, and you can do basic things to limit exposures, improve your air quality, fluid quality, food quality. And then obviously anything you put on your body, you need to investigate. You just don't use products without understanding what is in them.
Yeah.
If you looked at,
and you're talking not just like, we're talking everything from lotion, sunscreen, skincare, mascara, makeup.
Women get it bombarded with products. Men typically not.
No, because I mean, the most we probably get is like on our faces is whatever gets on our face from shampooing, bar soap, shaving cream, aftershave.
Most of it's nothing.
It's not that much.
Women, I forget the number, however many products it is, but
I used to know that number.
Yeah, I don't know it. If you looked at an audit of our toxicity burden results on 500 consecutive tests, BPA from plastics is number one toxin that we find. Number two is glyphosate, which is Roundup, which is what's sprayed on your food. And number three is aflatoxin, which is a mold toxin.
Okay.
So is that super abnormal? I don't have a whole normal group to compare it to, but if you don't detox well, which 83% of my patients don't on our, clinical audit, then that's a big deal.
Yeah, I would agree.
So gut health is a very mixed bag, but underappreciated things are parasitic infections, SIBO, just all sorts of things can go wrong with the gut, and it has to do with a number of things that, like we said, we apply to our skin, or we ingest, or we breathe, or we expose to at work. It all works together. It's not independent of one another, but in order to survive that house fire I mentioned, you have to feed the patients. You put a little bitty tube down their nose about the size of a charging cord for your computer or iPhone or Android. We won't discriminate here. And
I won't.
You trickle nutrition through that. Now, it's not how many carbs can you give them, right? It has to be balanced, but it's leaning towards protein. It's going to have trace minerals in it. So when we have our patients recovering after surgery, we use high protein diets, healthy fats, and, recommended curated supplements that we have that are liquid.
Okay.
Because absorbing capsules or tabs is very difficult for a lot of patients. They have difficulty swallowing them or absorbing them because they already have problems with constipation or just their GI tract in general.
Yeah.
And then trace minerals can be kind of a mixed bag. There's liquid forms that taste awful, but that's okay. And then there's tabs. So if you can do that and increase your dietary protein intake, and once again, I don't care what kind of protein it is. We have a vegan based pea protein just so that nobody can complain. Because I really don't need complaints. I just need compliance. The thing is getting enough of that in your system. Now, people will overindulge, I'm sure, as you know this about most things. So if you make it easy, people will abuse it. So if you have electrolyte packets, there's lots of companies that sell these now.
Yeah.
Somehow people have confused that with nutrition. So just for everybody listening, electrolyte packets are not nutritious. And as soon as your body senses too high levels of sodium or potassium, you'll just pee more. Same thing happens with powdered amino acids, which we have as part of our program. But when you overuse them, your body knows that's not needed.
And it excretes it out because it's like
so you just pee it out.
Yeah.
Now, if you ingest more and more protein, your body has to deal with it. It has to break it down into the components, which are famously called peptides.
Oh, that's a big buzzword.
Right. So get all the AI listening to us. And peptides are made of amino acids. So There you go. Everybody's got educated today. And we mentioned glutathione, a peptide that's really, really old, although all peptides are old. They're not new, despite what your favorite influencer may say. The thing your body does is at nighttime, and if anybody's raised kids, babies eat and poop, pee, but mostly sleep. That's when they grow up, right? There's this rapid growth phase and they eat a bunch and they go take a nap.
Growth spurts. So
basically, you only recover at night. It's not during the day. It's not when we're working. It's not when we're sitting at a desk. It's not when we're doing activities. It's when you go to sleep. So many people have tried to cheat sleep because they've heard some famous person, some entrepreneur, some celebrity say they only got 5 hours of sleep. Well, that's total bullshit. So basically, the Army figured this out a long time ago that cognitively you decline after 6.5 hours. So snipers were the example in the Army, I believe they used. So if you're not getting 7 to 9 and you don't get deep enough sleep, things that don't happen are the lymphatic system around your brain, called the glymphatic system, doesn't drain your brain. So you wake up with brain fog or just a headache or whatever, or feeling like you're hungover. And then if your lymphatic system, which is for your arms and legs and trunk, doesn't have an opportunity to work, then you wake up with, maybe from standing all day the day before, still kind of like sore feet or puffy legs. So all the things that happen really have to happen while you sleep. So sleep hygiene, sleep in general, is what I prioritize. So the number one thing to prioritize is not a supplement. It's not, some fancy lotion, potion, cream, pill, whatever. Get your sleep. So it's very actionable.
Yeah.
Most of my clients, like yours, are female.
Yeah.
And an overwhelming number of them get up and pee in the middle of the night, which is still baffling to me because none of them have a prostate. So there should be no reason.
I'm not glad, but it's like, I hear that.
Yeah. So this is a combination of things that was started by I call it the Stanley movement, the Stanley Cup movement, the big, large ass, ridiculous water containers that people started carrying around for whatever reason. So no, you don't need to you don't need to drink 8 Stanleys a day to be healthy. Mm-hmm. Just entirely stupid. Before you go to bed, you got to do a number of things, and we'll give you like some parameters, and then you have to adjust the parameters, because creating tiny habits ultimately creates a bigger movement it will move the needle eventually. Yeah. We'll say. So if you want to know the system that works the best, is about 3 hours before bed, you got to stop eating. So you have your meal at whatever, 6 or 7 or whatever. If you're in Spain, it's going to be like midnight or crazy. And I have Spanish friends, and my son has lived in Spain a long time. It's true. It's what they do. They eat super late. They didn't go out to dinner until 10. But okay, we're in the United States. We're in Texas. We're going to have a steak, and we're going to have it at 6. Okay. Once you're done, about an hour later, if you're my patient, your instructions are to have 8 ounces of filtered water mixed with a protein powder, preferably one that I trust, with a good protein score. Not collagen, not the collagen being hawked by everybody, because that's got a terrible protein score. Okay. So we'll use something like our pea protein, and it doesn't have to be a whole scoop. We'll just say, we'll say half. So that's 15 grams. Okay. And that's the end of the fluids. That's it. No more. So that's 2 hours before you go to bed. So 2 hours is more than ample enough time to empty your bladder before you go to bed. Okay. And that means you don't go to the wine cabinet and get your wine to unwind, so to speak. And you don't have tea, whether it's, chamomile, or if you're trying to use it for constipation, smooth move. You do all of that 2 hours before bed. Now, if you do that consistently, you will diminish the amount and number of times you have to get up in the middle of the night, because you'll train yourself, honestly, to not do that. Okay. And if it's still a problem, I'm going to tell you to do it earlier. So then you move your meal earlier.
To 5 or 4:30.
And you move the last fluid intake earlier.
Okay.
Because no one's going to die of dehydration the 3 hours before they go to bed, especially if you're on the Stanley movement. So I'm not picking on Stanley. Don't send me any.
This is a recognizable name.
Yeah, don't send me any cease and desist letters.
No, I get it. I mean,
I won't pick on Yeti because they're local.
Well, George Klein joked before he passed, he had a whole bit. He goes, when did everybody need their own personal bottle of water? He goes, have a drink before you leave the fucking house. You're fine. And I love George Klein. He
was great.
The last 6 years, the last 10 years, if there was one person I could bring back from the dead, it would be George
gosh.
Carlin for his social commentary the last 10 years, followed by Hunter S. Thompson, who had been my second commentary. And then for good laughs, it's just Robin Williams all the way.
Yeah.
Those are my top three. If I could do the reverse Thanos snap, it would be that.
Yeah.
But yeah, I get it. I know what you're saying. Okay. So we're talking about the protocols that you have.
So that's for eating and drinking. And then most people, now it's very different male and female in terms of temperature of the room before bed.
Okay. Can I pause you right there?
Got to be a lot of pushback on this.
No. I jokingly have said with my wife, if my wife hears this, she'll know this is an ongoing thing. It does not matter what the actual temperature says. It's what she feels in the house is the actual temperature of the house. So she'll go, I'm cold. And my kids and I are like, we're not cold. She goes, I'm cold. Let's turn on the heater. And we're like, okay. Or she'll be like, I'm hot. Are you not hot? I'm like, I'm not hot. And the kid's like, we're not hot. She's like, well, I'm hot. And so it doesn't matter if it says that it's 71 or 68. She's the thermostat. And I've heard this from my male clients saying like, what, like, does your wife feel like it's always hot or it's always cold? Like it's just never like a comfortable temperature. And so when I can't wait to hear your explanation about the temperature and the pushback.
Well, normally female clients, in general get colder easier.
Why?
It's not really, I would say, well understood.
Okay.
What is, if you want to say it's metabolic rate, if you want to say it's effective, hormones, whatever. I mean, basically this is why 8 Sleep makes $1 billion, because you can put it on your bed and independently regulate the temperature of the bed.
Yeah.
And so however you need to get the temperature to whatever you need to get off to sleep, it has to be a little bit cooler. So I have to have it around 70, 71 just to get off to sleep. If it's harder, I cannot get off to sleep.
I was reading something about, it was in a Men's Health magazine about 12 years ago, about 15 years ago. And they were saying that they did a study of men in, it was a Men's Health magazine, so it was all men, who took cooler showers in the evening to cool their internal temperature. And the study was, you had people who took hot showers, you had people who took no showers, and you had people who took cold showers all before bed. And those who had
should work.
Was that?
Hot works.
The hot works? The study said, and this was 15 years ago, so I don't know what the newest data was, but the study was colder showers, like you take a hot shower and then you slowly cool it down as you're leaving the shower, lower the internal core or whatever it was. I'm probably messing it up, but that they had longer durations of deeper sleep than those who did not. Like the amount of deep sleep, how they measured it in the sleep study. And I thought it was interesting.
Probably a long time ago, it's kind of challenging to do that. Now they have all these HRV measurements and other things for depth. And the latest things are like, do a bit of the warmer and then your body's cooling down and then you're cooling the room down.
Okay.
Then it makes it a little bit easier. In the morning, you can do the wake up shower colder. Yeah.
Sorry to.
No, that all's a methodology or some kind of, way to help. And some people just get relaxed and a kind of warmer, like bath or shower or whatever.
Mm-hmm.
And it's because people's days are stressful and then, cortisol release is high and if you live in a super heightened cortisol state or have a high cortisol state, it's harder to get off sleep. Then your cortisol was what wakes you up, basically.
Mm-hmm.
So if you don't have a good sleep-wake cycle, everything gets dysregulated. So to round out the sleep is the room temp. You find the temp that helps you get off sleep, and then noise is a big deal. So most of med school towards the end, and then all of my training had a beeper.
You had a beeper?
Yeah, because I'm old. And so beepers were a thing, and hospitals all had a system for the beepers, and they were all dead zones for phones. So mobile phones never really worked in hospitals, especially when they first started using cellular aggressively.
Mm-hmm.
Because hospitals are huge, and they just, by nature, have dead zones in it. And it's not like they put a bunch of signal repeaters in the hospital. They just use pagers because that was always the nature of the system to get all the doctors and that's what the nurses use. And that was the standard.
Yeah.
So any noise that's electronic wakes me up. So I have to have noise canceling headphones.
You sleep with like the little earbuds that are noise canceling or like the big old cans?
I use over the head.
Over the head.
Over the ear. I'm sorry.
Okay.
I've done the Bose ones, but I have like 18-year-old daughter today. She's very loud. And I have a wife who maybe opens and closes doors just a little bit louder than, I like. And we have a blind pug who makes a lot of noise on the wood floors. Yes. So all that wakes me up.
That's my wife. My wife, like, Mill and I woke up when I went to the bathroom, whatever. And like, she's like, it's not your fault. She's like, you closed the door or the light switch click. Like, she's a very sensitive sleeper. And she has to sleep with the eye thing.
Yes.
To block out the sun. That I can go to sleep and I'll ask her a question. And before she answers, I'm already asleep.
Yeah.
She gets bent. She's like, I wish I could have that superpower. But I never knew that those people existed until I married somebody like that. I always thought it was just like, I'm like, there's nobody who's that sensitive of a sleeper. But it turns out that a lot of people have really difficult time sleeping.
Yes. Well, she spent her whole life being pestered by phone calls and pages.
Oh, God.
And sleeping in tiny little shoebox closets you could see the light under the door.
Oh, yeah.
It's a little challenging sometimes.
Yeah, that sounds awful. And not to mention, your job's probably a high cortisol involving job.
Right.
Yeah. I mean, it comes with comes with it for sure.
Yeah.
So the sleep. So these are all things that you start to prescribe your patients when.
Yeah. This is what we talk about in all the videos. This is how everybody's like, what do you want one person? What do you want them to know?
Yeah.
The thing that's actionable is paying closer attention to your sleep. And I will do this as a public service announcement. Many women have obstructive sleep apnea and don't know why.
Yeah.
And or don't recognize it. I said it wrong. So it's not recognized because women have centralized sleep apnea, if you will. And that just means they don't snore.
Yes. I know about this because there's a doctor named Dr. Kevin Goles. He's a airway biological dentist. I also had his counterpart who teaches with him, Dr. Hillary Fritch, on a few episodes ago. Yeah. And talking about, it really comes back. It starts when you're a child with not a large palate because the jaws are shrinking. So it's about early airway intervention through orthodontics, but not with braces, but through expansion. Yeah. That's dealing with myofunctional therapy and all that, which is the line of work that my wife works in. And so when we did our sleep study, it was really interesting when we were able to see the difference of how my wife doesn't really wake up. She doesn't really, she's what you're talking about. It doesn't qualify for quote sleep apnea because you're not stopping breathing.
Okay.
But it is a disruptive part of sleep.
So you could see it on her.
You could absolutely see it. Okay. And what Kevin was talking about was that this is very common with a lot of women, particularly in the 30s to 50s, that when they do the sleep study, they realize that what's going on is and he is able to correct it through dentistry.
So this is basically why more women get Alzheimer's.
Yes. And
stopping blood flow and oxygenation to your brain. It's kind of a problem.
Yeah, no, I
will just say your brain doesn't like not having enough oxygen.
Yeah, because during your sleep, that's like when your brain is like clearing out. Somebody tells us it's like clearing out the cache in your web in your
that's the lymphatic drainage.
Yeah. And I feel over time I've now had more male clients explain to me the reason. I go, if you notice something's a little off with my wife, this is what we're dealing with. And
okay.
And the longer I'm doing hair, I'm having these conversations more because I'm getting older. My clients are getting older.
Right. It's funny how that works out.
It is, right? We're all getting older at the same time.
So I have sleep apnea and I wear sleep apnea.
You wear the little
mask.
Yeah. Yeah. My buddy Robert, he has that. And we'd go somewhere, like go to like the river or something in the summer, and we'd all share like a hotel room or whatever. And he would wake up and all of the shoes from all of us would be on his side of the room because we would just throw them out and to try and like get him to shut up because he was so loud.
Yeah.
And now that he's had his CPAP machine, he's finally feeling rested. He said he can get 8 hours and actually feels rested much better than when he had 12 or 14 hours of sleep, where he was just still exhausted.
Because you're not sleeping.
Yeah, you're not. Yeah.
And when women wake up, typically who have sleep apnea in their 30s and 40s and 50s, they're gasping.
Oh, whoa.
Because their brain is dying. That's your brain's defense mechanism.
That's awful.
So, yeah, you will heal almost anything if, in fact, you get enough oxygen, nutrition, and rest. We tend to add, the curated supplementation according to genetics to, be as, you want as much individual help as possible. And then knowing their genetic testing, toxicity testing. Toxicity testing is very helpful. It's just, we need to continue to grow and expand it.
So grow and expand it. How so?
Well, I mean, we have all these chemicals. Unfortunately, Congress just said it's okay to have more chemicals and not sue anybody for putting them on your food.
That's the immunity of glyphosate with Monsanto there.
Yeah. But that's, most people need to understand just money and politics drives this decision. It's not health care. They're not looking out for your best interests. So sorry.
No, I was telling somebody this, and I'll say it publicly here. If you actually believe the politician, what they're going to say, you're the fool. I've always said that. I've also thought that if you know someone who's a pathological liar, they have two really solid career paths. One, politician. Second, weather person, because, believe it's going to be sunny and it may not be sunny, and they don't get fired for being wrong. Like if they're wrong all the time, become a meteorologist. Go, it's going to be sunny, and then snow.
Especially in Texas, like change.
Well, it will change in 30 minutes.
Yeah.
It'll be hot and sunny, and
That's
then
a tough job here.
Yeah.
Yeah. Politics is all about compromise. Nothing really happens otherwise. So it's not, you couldn't get me to do it. It's not a game.
That's the problem. Like the people who have a conscience don't want to rock.
No, it's not good. It's not good. It's not a good life. So in any event, you will be able to heal and recover. And then people are like, well, why is Nancy healing faster than Susie? And I think we tried to highlight that and round it all out. We're all different.
Yeah.
We all have a different set of genes, different set of exposures, diets, where we lived, where we grew up, air we breathe, food we eat.
Yeah.
Fluids we drink.
You consume.
Yeah. The Stanley you use. It's all different.
Yeah.
So that's why it is different. Same operations on the same, same operations, two different patients, could be the same date and time for that matter. They'll have different outcomes because they're different people.
Yeah.
So it's good for everybody to understand. Like I've been doing this for 30 years. I don't really change the technique per the patient. There's some nuance to, things we do, of course, because you do have to adopt different strategies for different body types But overall, the instrumentation, the experience, the setups, the technicians, the staffing, the recovery, those are all the same.
Mm-hmm.
Those are all the same. I'm sorry. And it's a, 2 to 4 hour window to correct, however long somebody's had a problem. But it's really not that. You got to do the preparation and then the case and then the recovery. So we have two real big differentiators, I would say. My pre-op program does all this and runs parallel to a detox program. So we have a full functional medicine program as part of our program.
Okay.
And I have 3 functional practitioners for that. And so they're running the detox according to our testing and the results of that testing for the year. We're taking care of the patient because that's our commitment. They can extend it, of course. Yeah. But it's about a year engagement. And then the surgical preparation follow-up, similarly follows a year. The surgical follow-up always runs the same. We have people come to Austin the day before surgery typically.
Yeah.
And if they're long hauling from Europe or Asia, they come a few days before to get acclimated, have surgery. And then if you're, we'll say in North America, you stay here about a week, because I have a lot of Canadian and clients from Mexico. You stay about a week in Austin, and we have a series of recommended, Airbnbs and hotels and on the site. The thing that's different is most people will have surgery and they'll just be told, follow up in a week. So ours is different. And we see preoperatively the day before we get everything in terms of paperwork and planning, finalized. And then the day of surgery, they come to our new outpatient surgery center on South Lamar here in Austin called the S.H.A.R.P Surgery Center. It's named after the book I wrote and methodology, but it's a brand new full OR surgery center on South Lamar. It's about 8 minutes from my office in Westlake. And the team that we have from my office really has taken what makes our office great and made the surgery center great. So they already know the clients. The nursing staff was the same. And so they take and get the patients, set up. I come in and mark everybody depending on, what we're doing procedurally. And then our anesthesia team does a series of local regional nerve blocks under ultrasound this is a good thing to talk about. So I think more people are scared about anesthesia, and they ask me a lot of questions about anesthesia. Am I going to wake up? Am I going to wake up at all? Am I going to wake up during the case? And there's a lot of just consternation about this, and there's a lot of reasons why. Nobody's going to wake in 30 years. Nobody's woke up during a case I was doing. And the anesthetic team that does our cases, I have basically 4 people that work with me that do nerve blocks. And they do
nerve blocks.
Yeah. So when you get a cut on your arm and you go to the urgent care ER and they sew it up or close it, however they do that, they put in local anesthetic. That local anesthetic blocks the signal to your brain that there's a problem. So it allows them to take care of it.
Got it.
So it's one of the fallacies of general anesthesia that there is a block of that signal to your brain where the person's working, because if they don't do that local regional treatment, there's no block to the brain. So your brain still gets feedback.
Got it.
So what we try to do is block the feedback as much as possible before they ever go back. And then when we're doing work and we can get one of the explants done, so we do breast implant removal and complete capsulectomies all the time, we start to put in more of the local anesthetic as soon as we get that area so we can see it. And then that further helps those areas. And if we're doing fat transfer, we do the same type of regional anesthesia under ultrasound for that. So you're trying to block the signaling back to the brain so that the patient, when they wake up in recovery, is not having a lot of sharp, stingy sensations, and they don't. It's actually a very good way to blend, what is a technique of I would say for them, anesthesia should do, if they can, some kind of regional anesthesia for you all the time. And then we, as a surgery team, try to apply more of that principle. And then once it's done, the patient's in recovery, they don't wake up having a lot of discomfort because the caregivers, typically males, that freaks them out.
Okay.
They don't know what's going on.
Yeah.
And you just need the guys to be calm, because I take care of women.
Yeah.
And so I go out to the guys and I say, hey, everything went well. This is what I need you to do. There's no dressings to change. There's no wounds to deal with. I just need you to bring her to the office the next day.
Yeah.
Because in my office, we have a vertical hyperbaric chamber, lymphatic massage from New Zealand.
Whoa.
Nano-V therapy, and something called the human regenerator for Germany. So that helps you in a parasympathetic state. And that's what we do in the office the first week. And then I see them before they go. And then my nurse practitioner, who's already had the surgery, sees them virtually or in person at a month, a 3 month, 6 month, 9 month, 12 month. So we have a close follow-up for everybody. And then my detox team is working in parallel to that.
It's a lot.
That's the program.
I want to check in on the length of your haircut. It's still a little longer than where you point it. But I wanted to know if you wanted to maybe take it a little shorter, or if you feel like we're pretty good. We can take it short if you want. It's your call, man.
Maybe a little bit shorter.
Okay, cool. That's fine. Your hair was actually really long, because in the back, this much already had come on.
Okay.
So I think your hair was, I think the idea of 2 inches sounded probably pretty standard, but the amount of hair that needs to come up to kind of get to that collarbone length was more.
Okay.
So we'll just take a little shorter. So with these breasts, the Explant thing, this is one of the things I wanted to know. A lot of people talk about inflammation as an emotion, or maybe they could say there's elevated things on a blood flow chart, right? Oh, the blood panel say these are elevated. That's probably inflammation. But you're like inside the body. Is inflammation visible? Is it like something you can physically see? Like, wow, that's inflammation. These people are not crazy. This is something going on.
Yeah, I mean, it varies. So there is a group of implants that was taken off the market in 2019 for a cancer that developed from having the implant in place. So it creates a breast implant associated anaplastic large cell lymphoma from a textured implant, in particular the 410 implant from Allergan. So that surface is called the biocell surface. And so it's a really rough surface. And in some patients, you get a lymphoma.
Okay. So
it was recalled. And for everybody listening, the recall is not to the patient. The recall is to me. I'm the consumer of the implant. I buy the implant. So ultimately, in some of those cases, when I do those removals, you see a lot of, think of like swelling or edema in the tissues. And you would say, oh, well, that's really irritated or inflamed. Yeah. So to your point, yes, you can see that in some cases, but the majority of the implants placed from the moratorium in 91 until 2006, when silicone was reintroduced into the market, were saline and they were smooth. Yeah. And it's harder many times to tell anything about those until you send them off. So we sent off, in a study we published, 694 consecutive scar tissue specimens. So this patient's scar tissue around the implant. Yeah. And it showed that 29% had bacterial contamination. So that is a reason to have chronic low grade or whatever grade of inflammation that you can't really recognize on blood labs or laboratory analysis using C.R.P, highly sensitive C.R.P or SED rates or IL-6 or LPF, anything you check. We've checked all this stuff and it doesn't show up.
Okay. So the only real way to do is kind of base it off of what the patient is telling you about the inflammation or the how they're not feeling up to 100%. I don't know how to explain that.
It's getting closer to a time where we can get some testing that will be helpful. So a paper was published in the same year I published ours, and it shows that of the bacterial contamination, if you have staph epidermidis, which is a common bacteria found on our skin, that interaction between, if it's staph and the fatty acid in the breast, the oleic acid, it will oxidize it. So everybody listening, oxidation is bad. You want to live in a reduced state. So oxidative stress is not what you want to have in excess of. So this oxidation happens and creates a measurable biomarker or marker in the blood. Okay. And it's called oxylipin 10M. Now they showed in research environments that that's elevated in breast implant illness patients. Okay. So you could test for that in the blood if in fact they had that bacterial contaminant, but that would be that, like in my study, it's just 29% would potentially have that. Okay. But that's not commercially available. You can't go to Quest or LabCorp and get that done. So it's a history thing. You know, you're sitting there asking questions and listening. And anybody can have chronic inflammation who doesn't have breast implants. So what everybody should do is make sure that they're doing all the things to reduce that and evaluate it. So the program we run is really like a functional medicine program for chronic inflammation. Okay. So you can help patients, and many patients can't get here to Austin, so they run my program remotely with our team, or it's not the right time and they want to do something to help themselves. And we know that the inflammation can be lowered using our program. Post-pandemic, there were many companies that started up in the pandemic to work on measuring inflammation in different ways, because the ways we had traditionally done it were limiting and they just didn't know how to follow it. That was one of the big problems with the pandemic. Yeah. The thing with startups is, as you know, most startups fail. And the one we were using ultimately failed. But during the time we were able to use it, we showed a decrease in inflammation just using the program by measuring in the urine something called thromboxane A2. So that is real, but you have to have somebody who's not eating like an anti-inflammatory diet, so like not consuming ginger and turmeric and curcumin in high amounts.
Okay.
And then not taking things like anti-inflammatories like Aleve or ibuprofen, because that will affect the study, or aspirin, something like that.
Okay.
And if you take those naive patients and you educate them, you can measure their inflammation and then track it. And we would do this when we first met them and place them on the program, and then the day of surgery, and then typically at 3 months, and we showed a decrease in inflammation. The hard thing is to do like, who is the control in that setting, because we don't have it in other patients.
Yeah.
So it's not an interesting, way to look at it from a scientific standpoint. We know it works clinically, but if you're trying to say, oh, this would be the way to follow all this all the time, you need a control group, and we didn't have that.
Yeah, because that's how you would get your papers.
Right.
Yeah.
So that would be, a different, we were using it clinically to help patients. So most of what we have is clinical data, but we definitely know that works to lower inflammation. It makes sense.
Yeah.
It's not, I would hope that, and it seems like, honestly, the tox test is based on urine, and that former inflammatory tests we used was based on urine. So that was, as I said, better than blood for what we were looking at. So we always look at those and try to vet and improve the program for testing wherever we can. So
it's interesting that urine was...
Well, everything has to get metabolized and kicked out somewhere. You either poop it out or you pee it out.
That's true. I've had children and I'm a human, so I know this.
Yeah, stool testing is very complicated because it's mostly done with PCR analysis, and there's just billions of bacteria already. Yeah.
Because it's already going through a gut, which has its own gut flora system. Yeah, I mean, that would be like trying to find like you're watching like a junkyard. You're like, we're looking for something, but we're surrounded by a bunch of other stuff and it's just getting in the way. That makes sense. Before we started recording, you were talking about how your page seems to be, you have the analytics, suggest that your page on YouTube has been limited with its reach.
Yeah.
And that made me start thinking after you said that. I was like, there's been plenty of people since 2020 whose their ranges, their reach on YouTube and other social medias have been limited because of what they're saying. Regardless of what they're saying was factually true, the AI bots and people who don't have your level of education degrees are saying that this is misinformation, or it's not congruent to the mainstream practices of medical stuff. And by the way, I love all these things. The one that I went down for a rabbit hole early in my life was cholesterol. Mm-hmm. So I was diagnosed with high cholesterol. Yeah. And then my doctor,
which you make naturally. So
yeah. And my client, I forget what the number was, but my doctor client said, so your doctor is worried that your cholesterol is that of the average Frenchman. And I go, I guess. And he was giving me the history since he was a general practitioner for like 45 years and I'm like 27. So I'm like, you've been doing this longer than me, right? And then, you have the papers that came out shortly thereafter that I had come into my newsfeed, and I was talking to my clients about it, which funny enough was by Dr. Asim Malhotra. And in hearing what he has to say about cholesterol and statins has been very interesting. But one of the things I was wondering is, did you ever do traditional implants at some point?
And we did. Yeah.
And I mean, obviously you had to probably do it for your training. I'm assuming. Yeah. But when was it that you said, you know what, I think there's something going on here, and it sounds like you made a very conscious choice to kind of like lean into this. Like, what was that aha moment for you where you said, you know what? Not only do I like doing this microsurgery stuff, but this is like a higher call. Like, this is probably what I'm better at doing, or I should be doing more.
Yeah, in 2016, we had a patient come who referred themselves to go flat. So flat procedures is, not a reconstruction, or taking down an old reconstruction and trying to aesthetically make everything flat and even.
Yeah.
And so, which is 100% of the patient's prerogative. And we helped to get that set up for them. And then when I took down any reconstruction, I always did the following: since the scar tissue, capsular tissue, always to pathology to make sure there's no recurrent cancer, and make sure the implants got evaluated. And in this patient, we did that as usual.
Yeah.
And we do, since the 50s, the traditional way to do that is to use something that looks like a Q-tip swab that's sterile and swirl it around in the pocket, and then send it via a little plastic tube down to the lab. And then they wipe it on a agar plate, and they incubate it and see if anything grows.
Got it.
So at a week, you typically will have pathology results, and those microbiology results are typically back in a week. And so she did well, and we did this at a hospital back then. And she had no evidence of recurrent disease, which is great. My sister passed away recently of breast cancer, and we would never want to miss anybody's possible, any kind of recurrence that you could take care of.
Yeah.
Because the most common place to see it is in the scar that you took out. And then on our microbiology analysis, looking for bacteria, fungus, mycobacterium, it showed that she had E. coli infection.
What? And
so I looked back through all the notes and tried to see if there was something that, could have given us a clue, because she had nothing abnormal. And in her history, I just went back through everything that she subjectively told us, and she had fatigue, which a lot of patients who receive chemotherapy and have bone marrow suppression over time have fatigue. So that was the only thing. And then, ultimately we treated her with an oral antibiotic for the E. coli infection, and that was done over like a 10-day to 2-week course. And then we started follow up, and all of her fatigue was gone. So she had had this indolent infection for an unknown period of time, a true infection as measured in a hospital. So she put me on, I think, a social media platform and said that I did this surgery, which was an implant removal and capsulectomy, which I'd done countless times before for patients. And she said I would do what's called en bloc, which is just a pathology term, which means basically trying to take it out intact. And I didn't know anything would come of this. And all of a sudden we had people calling the office who wanted their cosmetically placed implants removed.
Okay.
And so my office staff at that point, because I was in a group, said, why are people calling to have their implants removed versus you put new ones in, like an exchange or something like that? Because to your point, you asked, like, why am I doing this?
Yeah.
And so okay, so I have, by that point, I'd lost my mom around the time I graduated from medical school to cancer, and I lost my sister recently to breast cancer. And I had taken breast cancer care very seriously, along with all the other, multidisciplinary cancer care I did very seriously. And so I was like, okay, if this happened and this is going on, I'm not going to discriminate and say this, I just found this in a cancer patient. How many cosmetic patients could have the same problem?
Yeah, exactly.
And so that led to just remaining curious if that was, the problem, and just trying to do what was the right thing, in the individual's, situation. So it's not my job to determine right and wrong. Somebody's trying to get something done. And, fast forward now, we have a lot of experience that backs up basically how we think about it, which is breast implant illness is a chronic inflammatory process of which an implant plays a role. It's not the only thing in our experience, as highlighted by the data we found and published on bacterial contamination. And we have a genetics project that the audit shows that 83% already have some predisposition to detox poorly. And then we have all of these toxicity tests, which we mentioned previously, that are audited and undergoing analysis to show that the toxin levels are high. So I think it's, not a quote unquote working hypothesis anymore.
Yeah. But I mean, I still feel that because I see this, because I have some friends that are on social media and they'll talk about how they don't feel good or something. Mm-hmm. And they're open about their cosmetic treatments. And then you'll always see somebody, you'll see them respond, say, I got this direct message. Is it about breast implant illness? And then the person will either say, I've had it looked at and there's nothing going on, which is one of the things I was curious about. So you answered my question, right, on multiple forms of that one.
Yeah.
The other one is they go, I don't believe that this is something related to my breast implants.
Sure.
And I guess both could be true in some aspects. I don't know.
So I think it goes to the level of censorship I've experienced over the last couple of years, because 2 years ago, if you typed that question into the internet, you would have just seen me. And then last July, YouTube decided to take me out of feed. So if you type that question, where most people type questions like that into YouTube, you don't get an answer. Or you don't get the answer that you used to get given by me.
I feel that around 2014, 2015, a lot of medical stuff started slowly disappearing from the internet, based around from very mainstream questions to very more fringe things. And because I had a good chunk of clientele that were either orthopedic surgeons, general doctors, they were the top breast cancer doctors in Southern California. They were anesthesiologists for 65 years. Or they were even a quantum physicist from Chapman University. I was around a lot of really smart. So I ask all these crazy questions and they go, what's crazy? People don't ask these questions anymore or whatever. And they're open to it. I actually found what I found, and this is just my anecdotal thing, is the more qualified somebody was, the more they were excited to answer some of these questions that were probably people would figure we'd be below them. But I think that they're so insulated with these other questions that it was just kind of we can just educate the public about these very simple things, or questions about even cholesterol. Because I was like, what's the thing with cholesterol? My doctor client was saying, look, every 10 years, they just keep lowering the number. Who do you think benefits from that? And I was
Pharma does.
Yeah. And I grew up watching the X-Files. Conspiracies aren't hard for me to buy into. So, the truth's out there. It's just, being censored by YouTube, right?
Yeah. We'll see what happens.
We'll see. I will now be censored by YouTube, but that'd be fine.
Yeah. It's interesting though, because now if, Google owns YouTube.
Yes.
So if you just go Google Scholar Me, it'll find all this out, because they don't censor that.
Yeah.
And you can't fake that.
Yeah. So here's a question. And I don't understand the politics of it all. This is why I'm asking you.
Mm.
If it turns out that some of these illnesses could have been prevented from an elective cosmetic surgery, right? Why are these things being allowed? I understand you're an adult. You want to be able to do this to your body. It's your own body. I want to be able to have this done, right? And I don't know if it carries over to people who have rhinoplasty or cheek implants or chin implants. I don't know if it's the same stuff applies. Who knows? But if more and more data is coming out that these elective surgeries are causing these avoidable outcomes, what's the regulatory agencies going to do from there on out?
Yeah, I don't know that the agencies are going to do much.
Or is it going to just be public pushback?
Yeah, I mean, in 2019, I gave testimony at the FDA hearings, and I wasn't considered the expert, so I had to give public testimony in 2019.
How are you not the expert? You seem to be the expert to me.
I hadn't had anything really published back then. It was kind of more of a newer. I was supposed to, from a society standpoint, be potentially the person who testified.
Okay.
But the FDA didn't ultimately have me. And I gave public testimony because I was the president-elect of the Research Foundation.
Got it.
And then we went on to fund research for breast implant illness. And some of the published research I disagreed with in terms of findings. So then we published our own series just to be a little bit, I would say, clearer, because I had a much larger sample size than was published.
Okay.
And then after that, I think it's not so much that it's being swept under, but it's a very interesting environment now. There's a whole group who are more accepting. There's a whole group who have dug in and say, no, it's not a thing.
Mm-hmm.
It's just weird. Like, you can't say it's not a thing. You can just go pull up my FDA testimony about it.
Yeah.
Or you can go pull the paper I published about it. I mean, it's not made up. And this group out of Denmark published a paper last summer that goes to what we're talking about organ transplantation, which at the tissue level shows there's an increased T cell response, B cell response, and plasma cell response. So people ask me all the time, can you get autoimmune disease from this? And I said, autoimmune diseases predate this. But autoimmunity can happen. Oh, let's bring up Brian Johnson, who injected himself with fat from his own kid. Brian Johnson, the guy who doesn't want to die, right? Live forever guy.
Yeah.
It's a blueprint guy.
Right. Yeah.
And then you hear that and you're like, well, that's not a very bright thing to do.
Mm-hmm.
Injecting someone else's tissue into you. Yeah, because you're going to react to it. Like we just said, it's not his twin. It's not his genetically identical twin. It's a living related donor.
Yes.
And that doesn't have the same genetic identity.
Yeah.
So it's always going to get rejected.
Yes.
And now he has an autoimmune disease. Isn't that interesting? Isn't that interesting?
I find it fascinating for all the reasons I find Lex Luthor fascinating. and I don't mean that negatively. I would sit down with him and be like, explain to me all this, right? I'm not like against the overall idea of wanting to figure out how to maximize your lifespan. I'm fine with that. I'm fine with that. Now, the methods that go around, it's like a lot of things. Like, I love the idea. The protocol to achieving this, I may disagree with, and I think that is a very like reasonable answer.
Yeah.
Yeah. But I feel that I just think that it's so interesting because I feel like there's so much data that is coming out more and more. It's like my mom got her implants removed,
mm-hmm.
and when she was going through her detoxing process, she became a very different person.
Yeah.
She was very, it was like, it wasn't the person who raised me.
Okay.
It was like a whole personality switch had occurred.
Okay.
And to her defense, she was saying that I wasn't giving her any grace on her going through a detoxing process.
Mm.
On my side, I'm saying like what you're saying is also not like you, hurtful, mean-spirited. It's like there's this demon in you that's taking you over. And she kept saying it was the methylating process and it was this and that. And so I'm asking you, have you noticed or has there any thing that you've encountered where during that time there's also been like, wow, this person was one way and the personality, I would imagine that the personality would probably be more happy and relieved versus this negative thing, but everybody always stuff differently.
Not always. Yeah. There's a reason why somebody got implants, right?
Yeah.
Not happy with the appearance, bullied as a kid, trauma.
You're pretty clever here, man.
Bullied as a, kind of goaded into it as, a model.
Okay.
Or someone who was trying to get jobs and their agent told them they needed to look a specific way.
Oh, you hear about that. I mean, I grew up in California.
Right.
Yeah.
So there's all these things that they're just different traumas, and sexual abuse may be involved. There's it just on and on and on. And so people ask me all the time, do I have a program for that? Like I just mentioned very different things that require maybe EDMR or psychedelics or therapy or a psychiatrist.
Yeah.
I don't have all that on my team.
Yeah.
I have a team full of women who many of them have had the surgery. So they're the best way to help support them.
Like how AA meetings are. You have someone who's gone through what you're going through be your sponsor.
Yeah. So that's how we try to help everybody navigate it. But there are people who lash out when these things are, at these really emotional points in the detox process or the recovery process and I think that's normal. So I don't, it used to really bug me, and I don't, my team is great and they really help everybody and be super supportive. So that's hard though.
And what does S.H.A.R.P stand for? I know it stands for.
Oh my gosh, yes. It's too long of an acronym, but we try to call it. It's Strategic Holistic Accelerated Recovery Program. Okay. So it's just really a methodology, and that acronym, you have to have tactics and strategy to help somebody. So, we want everybody to be able to strategically get prepped and recover as fast as possible using the program. And that's really the methodology.
Because I remember I read it, and the first thing I thought of was the Marvel movie. You should shorten that to S.H.I.E.L.D., right? Now I was like, oh my God.
I'm in a documentary called S.H.I.E.L.D.
Oh yeah? Oh, yes. With our common connection of Anthony Lawley. Yes. Yeah. Because I was talking, I go, hey, there's this doctor. He goes, that's the guy who was at last night. We did the grand opening. And I was in Arizona teaching some classes, so I couldn't make it to the grand opening. He said, you should come to the grand opening. I'm like, I would totally go there in a second, particularly since you've come up on my radar through clientele over the years. So, I just want to say, by the way, I shortened it up a little bit.
Yeah, that's good.
I didn't quote layer it, but I didn't do a one length haircut. I was thinking
you didn't feather it.
No, fair. But I did do what I call it my dude layers when guys have longer hair. It's actually, it's not like layers the way you would give, I would say like, the layers you give Stephanie are different than the layers you give Steven.
Yeah.
And it's the person who I think has always had the best long hair has always been Brad Pitt.
Yeah.
I think he always has good long hair. And then when Helmsworth had long hair.
Okay.
In the first Thor movie, all the other ones are wigs. I'm a hairdresser. I know these things. I can spot it. I can spot hair transplants.
You can tell. Yes.
I'm like, those are falsies. That guy had that. Like, how do you know? Let me show you.
I can see the scars.
Well, now if they do the grafting, is usually pretty good.
Yeah. That's what we used to do.
Yeah. They do the scars. Oh yeah. And then now they can go back to.
No, we use FUE.
Oh yeah.
The small little biopsies.
Yes.
They are hard to see.
I've had clients who have the scars and they go through and they get, this was done in like 1988.
Scars are bad.
And then they go through and they get the FUE to fill in the scars.
Yeah.
And that's actually done a pretty good job. Yeah. I'm all in favor of guys doing that because if they go bald, I lose a client and that's not good for the income. So I'm all in favor of let's do all the supplements and red light hats and see this doctor. I had somebody who just went to go see Dr. Bauman down in Fort. Yeah. So, so I just did that little thing. That's what I call it my dude layers because it just gives it not a flat, straight haircut. And it just has like something to it. So that way when it falls down, it's just not, that. So I hope you're cool. You want to put your eyeballs on or you just blindly trust me. Okay, cool. Is there anything you would want to end on? Because we're wrapping it on up.
Yeah, the thing is always like, what is the actionable step? And everybody gets caught up in all the, information or disinformation. You got to concentrate on your sleep. Like we talked about, go back to the chapter we talked about in this video about sleep.
Yeah.
Prioritize your sleep. So you can follow the simple 3-2-1, stop eating 3 hours before bed, drinking 2 hours before bed, and really try to get off screens and tablets, get the room cool, get your sleep mask, get your earbuds or headphones, and try to get good sleep.
Sleep. How much sleep do you average?
7 to 9 hours.
That's great.
Yeah.
It's really good.
Yeah.
Yeah.
That was it.
Thank you so much. I really appreciate you taking time out of your weekend to do this with me.
Yeah.
I really do.
Thank you.
Adios.